I'm the Director of Vascular CT and MRI. Today we're going to talk about acute aortic syndromes. We're going to review anatomy and findings, some classification and complications, pearls and pitfalls of image interpretation, then at the end we'll do some cases. I know it's lunchtime, so try to stay awake.
Hey Leo, you sleepy bub?
It's my son trying to stay awake in Trader Joe's after a heavy lunch, so I know it's difficult. Okay, so first let's talk about aneurysm. Okay, aortic aneurysm, there is an association with smoking, elderly hypertensive patients, and we'll see that that's going to be sort of a theme. The patient population, older people, hypertension. Most discovered incidentally in asymptomatic patients, aneurysms. Typically you only have symptoms when it's late in the game. So that indicates rapid expansion of the aneurysm or complications from rupture. You can have mass effect on the recurrent laryngeal nerve, leading to stridor and cough, hoarseness. Patients also describe the feeling of impending doom whenever there's a rupture in their extravasating contrast and hypotension and shock. If we look at aortic measurements, we always obtain the measurements at standard levels, and we teach you how to do that when you come on the rotation. These are the standard levels that we use: sinotubular junction, ascending aorta, and at every specific level we measure where the aorta is the biggest in that level. Descending, aortic hiatus. The aortic hiatus is a good level to measure because it's the least likely level to become aneurysmal. So you can use that as an internal control when patients don't fall on the body surface area charts. We also measure both common iliacs. And the way we do the measurements is short axis to the aorta. This is an example of the sinus of Valsalva measurement. We measure cusp to commissure. That's how we do it for all three cusps, and we include the wall in the measurement. This is an example of an abnormal. Here you can see that this is 5.6 centimeters here in the right sinus of Valsalva. This is a right sinus of Valsalva aneurysm. Here's an example of how to do the measurement in a routine ascending aortic aneurysm here. So we're short axis to the center line of the aorta, and you can see that in the 3D view here. We have the 3D crosshair on, which shows the plane that we're cutting through the aorta. We include both walls here in the measurement. So once we're short axis, we want the major axis of the ellipse, and then perpendicular to that, which is the minor axis of the ellipse. If we look at the guidelines for thoracic aortic diameters, these are body surface area charts here, and you can see based on body surface area, so in this particular chart, up to 4.2 could potentially be normal in this particular example. If you look at the patient's age and also level of the aorta, if you take an 80-year-old person, in the ascending aorta, potentially 4.4, so that number you guys hear me talk about, that's where that number comes from, this graph. So that could potentially be normal in that person. Also, as we go down the aorta and branch vessels come off, we expect the normal tapering. And these are the ranges that we see for the tapering of the aorta. If we look at management of patients that have disease, well, the hinge point that we talked about in the question is 6 centimeters. So what that means is when patients, if you let the aneurysm get to this point, the percentage of patients having complications goes way up. So we don't want to wait till it gets to that point. We want to fix it earlier. So 5.5 that's why the number is 5.5 in that document. If you have patients that have genetic issues with connective tissue disorders, well, they change the range. So anything from 4 to 5. So I don't know why they just didn't say 4 instead of 4 to 5. It would make it simpler. So anything over 4, potentially they could operate on. If you have patients, the absolute threshold is 5.5, but if you grow at a rate more than half a centimeter per year in any part of the aorta, that's an indication to fix it. Also, if you're going for a repair of the valve, and the patient's ascending aorta is at least 4.5 at that time, because that number is higher than that 4.4 number, which is the maximum possible normal number for an ascending aorta, that they will go ahead and fix the ascending aorta when they fix the valve, so the patients get 1 sternotomy and not 2. They changed the rules on bicuspid disease. Just to review the bicuspid types here, we have the different Seaver types and examples. So Seaver 0 actually looks like a 0, where you see really 2 distinct symmetric leaflets or cusps here. Sievers 1 and 2, we see the normal three-cusp configuration, but we have failure of separation of the commissure here. So failure of separation of one commissure. Here we have failure of separation of two commissures, so that's a Siever 2. This is a Siever 1. So what they did in bicuspid valves, the number used to be 4.5, but they changed that number to 5. So they realized that patients with bicuspid valves, they do rupture earlier, but it's only half a centimeter earlier. It's not a whole centimeter. So instead of 4.5, they wait till they get to 5 centimeters. This is an example of a very large aneurysm involving the arch in the ascending aorta. This was a patient with tertiary syphilis who had never seen a doctor before. Patient actually presented with dyspnea on exertion and shortness of breath. And we can see compression of the main pulmonary artery. Lower extremity edema the patient had also. This is the cause of the symptoms. Unfortunately, he didn't survive the surgery. You can see the massive right-sided pressure being greater than the left-sided pressure here. We see a D-shaped ventricle, flattening of the septum here. Okay, let's move on to dissection. So here's an example of a cartoon of a dissection. I animated this weekend. No, I'm just kidding. I ripped it off from somebody. So here we have the intimal breach. Blood excesses and propagates the intima, lifting the media, creates two lumens. We have a true and a false lumen. You can potentially stop and have a re-entry tear, so you can break back into the true lumen. The false lumen can also thrombose. If we look at sensitivity and specificity of CT findings, they approach 100%. We're looking directly for the flap within the aorta. We'll talk about false lumen versus true lumen and additional unenhanced features. First, let's review the anatomy. So the intima is only 1 or 2 cell layers thick. So whenever we describe the visualization of a flap, it has to involve more than intima, otherwise we wouldn't be able to see it. So it's an intimomedial flap. If we look at the adventitia in the vasa vasorum, well, that's mostly a resilient layer of collagen, has vasa vasorum in nerves, not a lot of elastic. Well, we have elastic layer of collagen there. If we look at the media, which is the thickest layer, what I want you to notice is all of the elastic fibers that we have. So we have an internal elastic lamina. We have fenestrated sheets of elastic fibers. Layers of elastic fibers arranged concentrically. And we have an external elastic lamina. So basically there's a lot of elasticity in this flap. That's what we're getting at. And that's going to describe what we can see between the true and the false lumen. So first, if we look at contrast opacification, we have two phases here. We have an early arterial phase on the top, and we have a delayed phase on the bottom. If we look at the bright contrast in the true lumen, it's also bright in the ascending aorta. So this has to do with the where you are in the bolus. So this is the exact same bolus in the same patient. So when we image early, the flow is quickest in the true lumen because the resistance is low. There's no resistance to flow. In the false lumen, the resistance is high because you don't have the equal outflow that you do in the true lumen. So with the higher resistance, it's going to take longer time to get contrast into that false lumen, so you will not see it enhance as avidly an early arterial phase. The same mechanics explain the washout phenomenon. So we're going to wash out quicker. We're going to wash out slower in the delayed phase. So depending on when you're imaged, the bright lumen could be brighter. The false lumen could potentially be brighter, as we see here. Size, typically the true lumen is smaller than the false lumen, and that has to do with the elastic fibers make that flap want to compress into a smaller shape. That, coupled with the increased pressure in the false lumen, lead to smaller sizes in the true lumen. Contour, typically we're going to see what's called the claw sign, which is this. That's also called the beak sign, and that's a feature of the false lumen. We have that acute angle there, so that contour is a feature of the false lumen. The location of the flap, typically the false lumen will be on the greater curvature of the aortic arch. The true lumen will be on the lesser curvature. Then it will sort of spiral anterior to have the mesenteric vessels come off the true lumen with the left renal coming off of the false lumen. That's a typical pattern. But flaps can spiral all the way around. Any vessel can come off of each lumen. These are just the common patterns. Ultimately, you want to trace that contrast back into the true lumen proximal to the dissection flap. That's the only way to be sure. An unenhanced feature that you can look for is displacement of intimal calcification. So because the calcification is a feature of the intima, when we have an intimal medial flap displace that layer, well then we no longer have the possibility to have calcium along basically the middle of the wall. That's where it would be. So we don't see calcium as a feature of the false lumen in I- studies. MR findings. So again, we want to directly visualize the flap. We see the true lumen here, which has higher flow, so less artifact in this particular pulse sequence than the false lumen. Here is a contrast-enhanced MRA sequence where we should have equal opacification of both lumens here. So we see the smaller true lumen. We do see a little bit of mural thrombus in the false lumen, which can happen. When you do MRA for dissection, it's very important that you have a high-quality program and to make sure that you're doing diagnostic quality studies. Here's an example of diagnostic quality black blood imaging. And to get this level of imaging, it's 1 breath hold per slice, so it's very time-consuming. Here you can directly visualize the flap here in the chest. Here's another example in the abdomen. Also remember that these slices are 8 millimeters thick, so if we're looking for a tiny flap, we have no chance with this particular technique. But that's an example of a good quality MR. Here's an example of a bad quality MR. For a couple reasons. We do see a fair amount of motion in the vessel itself, but we also see motion that's sort of matched to the chest wall, so that's breathing motion. So if you don't have a patient that's a good breath holder, can't tolerate the exam, they're not going to be a good candidate for MRA. Here's some more examples of very high quality MRA that we can do. These are all three of these techniques these are different techniques. They're all non-contrast techniques, okay? So first, and our easiest technique is to take the pulse sequence that we use in cardiac MRI and just instead of using 25 phases of the cardiac cycle, we get 1 phase of the cardiac cycle and we just run it free breathing through the chest, and that's what we're seeing here. So the temporal resolution of any given slice is on the order of milliseconds. So we don't see blurry motion. You will see the patient breathe, but notice you don't see blurry motion when the patient's breathing. So this is a great technique, and this is really easy to get. You don't even need gating to do this. So any tech should be able to get this done on any patient without the need for breath holding. You can even do this without gating. These two techniques do require gating. So this is 3D SSFP, which is a gated version of this, where we take that 1 phase and we acquire a 3D volume of that phase. We typically do it in diastole. You can get motion-free images here. You get a full volume here that we can reformat, we can measure. Here we can look for flaps. We have a black blood version of this. It's called T1 space. These are actually the exact same spatial resolution. We just copy the settings from one and apply it to the other, including the scan range and everything. These are both free breathing techniques. So we navigate over the diaphragm, so we only acquire when the patient's breathing is in expiration. So you don't even have to have a patient that can breath hold to acquire these images. Bam! Free breathing MRI.
Is the reason we don't need gating also because the temporal resolution is so small? It's just a second.
Well, we're just acquiring 1 phase of the cardiac cycle, right? And that's the other reason. That it doesn't really matter what part of the cardiac cycle that you're in for that. Now, you get a better quality image if you do it gated. With SSFP, during systole, you have high flow. Actually, it's a method that's used to do non-contrast MRA. They do SSFP, gated, and do a subtraction, systole versus diastole. They use the difference in signal versus systole and diastole, and that's how they do the subtraction. But it's gated, so if your gating doesn't work, that doesn't work. But yeah, that's another reason to do it gated, is to do it with less artifacts. So we do apply gating, but you could do pulse gating and get the same results as doing ECG gating if you're just trying to get in diastole, which makes a difference logistically for the techs. Okay, let's talk about classification. Stanford is the classification that's currently used. Type A involves the ascending aorta, which is surgical management. Type B involves the descending aorta, which is medical management. Unfortunately, the Stanford group didn't say what you're supposed to do with the arch. Why do type A's benefit from surgery? Well, it really has to do with the risks that we're trying to mitigate from the surgery. These all have to do pretty much with the location of the pericardial reflection. So the main risk we're trying to mitigate is if we have a type A, here we have a type A IMH with a hemopericardium, so that equals rupture. So we're trying to mitigate any further rupture into the pericardial space and cardiac tamponade death from cardiac tamponade. So if our dissection flap starts above this pericardial reflection, well, the surgery doing an ascending aortic graft repair isn't really going to affect that flap. And it's not going to, because if that flap ruptured the aorta out here, we're not going to have tamponade. We're going to have other issues, but we're not going to die from tamponade, which is the main thing that kills people. Also, extension into the coronary artery, extension into the valve with acute aortic regurgitation. Those things can also lead to poor outcomes for patients. So we can't see the pericardial reflection, but we use the brachiocephalic trunk as the cut point for type A. Here's an example of a type A. Here in the arch, we don't know at this level, but here, this flap should be involving the ascending aorta at that level because here we're below the pulmonary artery. This is a great slide that Elizabeth George put together, actually. She segmented the flap here, which is kind of cool. So what about the arch in this confusion that the Stanford group left us with? Well, there was a paper that came out in 2014 with subclassifies the arch into type B and type B with arch involvement. The problem with type Bs is that there isn't a huge bank of data of outcomes, patients having surgery versus medical management, isolated type Bs. That's the problem. So they really don't know what to do. The surgery for type A's is an ascending aortic interposition graft repair. It's a different surgery if you have the arch involved. If the arch is involved, you have to do a hemiarch, which is a much bigger surgery. So they try not to operate if it's just the arch because the surgery and the morbidity from that is so large. They only do it if the patient's having stroke symptoms or if they're having rupture or expansion of the arch. So they try to avoid it. Okay, complications, rupture, hemopericardium, we talked about that. Hemomediastinum is also a serious complication, as well as hemothorax and retroperitoneal hematoma. We want to look for branch vessel involvement, thrombosis, end organ ischemia, and then aneurysm development, either acutely or in the follow-up period. So here's an example of a case. We see an intimal flap here in the ascending aorta. We see it again on the long axis view. We see hemopericardium there. We have the nice golden arrow sign showing us the flap there in the ascending aorta. So this is a ruptured type A with hemopericardium. When we look at branch vessel involvement, here's an example of the vessels coming off the aortic arch. So we have the brachiocephalic and the left subclavian. This is a great case from Ron, actually gave me this case from when he was a fellow at MGH. We see the flap directly going into the left main, which is awesome. And I haven't seen it since. So usually the patients, if they end up with this, a lot of times they end up going straight to the OR, so we don't image them. But here's an example of end organ ischemia of the renal variants. Here we see the flap going into the right kidney, which the vessel is thrombosed. Here's another case. We have end organ ischemia of the SMA here. This patient was a type A dissection, actually, and I colored in every part that was thrombosed. So you see the branch vessels going to the brain, the part going to the SMA, the iliac, internal iliac with a really large iliac aneurysm. So let's review some imaging pearls and pitfalls. We'll look at artifacts.
Quick question about
Yes.
the end organ ischemia. What if it's just, but tiny, like it's just underused because of the difference in the flow? Like if you do delayed imaging
Yeah, you'd want to do a delayed scan.
to make sure that it's
For sure.
actually thrombosed
Yep.
as opposed to-
Definitely.
Okay.
Yep. We'll take a look at mistaking other structures for dissection and misclassification of type of dissection, failure to recognize alternative diagnosis. So let's review some technical artifacts here. So this is a pulsation artifact where we have the aorta right next to the right atrial appendage that mimics a dissection. Here's another example. Here we have surgical clips from a patient that's had coronary artery bypass grafting, and we see the streak artifacts coming off of that. Here's an example of an interpretation error. So let's review the different ones that can make dissection imaging tricky. Here's the right atrial appendage. Sometimes that can mimic a dissection flap. Superior pericardial recess. This one actually can be tricky on those SSFP cases because fluid is bright on those, so you have to be aware of that. Superior intercostal vein, that's another tricky one. The left inferior pulmonary vein. Here's an example of an interpretation error. So if we take a look, this was misclassified as a type B dissection. If we see the flap here, if you use the 3D workstation, you can see that we're below that level of the brachiocephalic trunk. So this would be a type A. So that delayed the treatment for a couple days for this patient. Once there's dissension in the ranks, if a radiologist calls it type B at some point, and then it shows to somebody else and they call it type A, the surgeons will send the patient to the unit and wait. They won't operate if there's any confusion. They'll let everybody figure it out. But so it's very important to be accurate initially when you communicate with the surgeon. Interpretation errors. So this is the case actually that we showed earlier, the one with the streak. I'll run it through again. And this is an outside study. And the contrast is not great in the ascending, I'll give you that. So we repeated it with proper contrast timing. And this was a missed type A dissection, actually, which is pretty scary. So if you go back and look at the streak, so one is kind of coming in a sort of a weird angle that you wouldn't expect from the streak of the clips. So that was what triggered my colleague at the time who made this call. So that was a good pickup. Here's an example of an interpretation error. 68-year-old male with a history of hypertension presents with syncope and back pain. Here we have a massive saddle embolus. So the teaching point for this case for me, and I try to go over this with everybody when they rotate, is if you have bright enough Hounsfield units in either your pulmonary artery or your aorta, and it's either a pulmonary artery study or an aortic study, it doesn't really matter if it's a pulmonary study or an aortic study. Always look for both. If you have at least 200 Hounsfield units either in the ascending aorta or in the pulmonary artery, you can diagnose dissection or PE, so you have to look for both. The tendency as well was an aortic study, so you're not going to look for PE or vice versa. Here the patient had a massive renal cell with thrombus that embolized. Okay, let's move on to intramural hematoma. So here we see an example of a type A intramural hematoma. The main theory is rupture of the vasa vasorum resulting in subintimal hemorrhage with intact intima above. Chest or back pain is the most common chief complaint, exactly the same as dissection. Very similar patient population to dissection 2, older hypertensive patients. Here's another example. And what we're looking for is the crescentic rim of hyperdensity. That's the pattern that we're looking for. It's great if we have an I-. If we don't have an I- and we just have contrast on board, we need to make the diagnosis of a crescentic rim of stuff, right? Just because you have contrast on board doesn't mean the patient doesn't have an IMH. And you don't need an I- to make the diagnosis. Here's an example of one where we have both contrast and I-. So there's no intimal breach in an IMH, which distinguishes it from dissection pathologically. There is this entity of the thrombose dissection, which I think most of the time would be these cases where we just image too early and we're not filling completely the false lumen versus just a dissection. That's been my experience most of the time. This thrombose dissection thing is way, way, way less common than we were led to believe initially. So hyperdense smooth crescentic wall. Again, a lot of these cases you need to pick it up with just this image. So look for the smooth crescentic wall. Does not enhance following IV contrast material. It's a hematoma, so why would a hematoma enhance? With the exception, the intramural blood pool, which we'll talk about in a minute. The aortic lumen may or may not be narrowed. Supposedly the thickness of the IMH does correlate with how the patients do, but that's not a feature that we routinely measure. Here's an example of how it looks on an MRI. So here we have black blood imaging. So we have blights, and this is a T2 weighted FAT-SAT double inversion recovery. So it's black blood, T2 weighted with FAT-SAT. So acute hemorrhage here is bright. These other images are the MRA. So this is early arterial phase. We see just enhancement of the lumen. We don't see enhancement of the IMH. This patient had aortitis. and had subsequent IMH as a consequence of the aortitis. So we see all of this straining around the aorta and enhancement of the wall. That's because of the aortitis. The Chinese ring sword sign, arguably the coolest sign in radiology, definitely the coolest sign in cardiovascular radiology. So we have all of these branch artery pseudoaneurysms, which appear like the Chinese ring sword. So this interventional radiology group sought to define what this is and follow the patients over years and see, does having this feature portend a worse prognosis for the patient. So this is pretty awesome how they did a 3-part series. I don't know if they knew they were going to do a 3-part series because the last paper was published 7 years after the first paper, but they did label it part 1, so they knew there were going to be a part 2, which I thought was cool. Okay, and this is the group out of Michigan, I think, that did this. So if we look at branch artery pseudoaneurysms, and these are figures from the paper, here we see a normal lumen and a normal lumen with a branch artery coming off. When we have the intramedial hemorrhage, we see the two layers of the wall starting to separate, and the hemorrhage is starting to approach the ostium of that branch artery vessel, and here it crosses that ostium, tearing through it as it crosses the ostium. So then what develops is a contained rupture inside the wall. So we have a pseudoaneurysm inside the wall of the aorta, and that's key. This is not a pseudoaneurysm of the aorta, which would be a surgical treatment where we'd have to fix the aorta. They actually went in with catheters and cannulated the branch artery pseudoaneurysm from the ostium of the intercostal directly. So that's how they proved it. One of the tricky things back then was they couldn't see the ostium on CT because the image slices were too thick. So intercostals are tiny vessels, right? They're 1 millimeter, typically, maybe 2 millimeters. So the ostium's that small. So if you're reading 5 millimeter thick images, which is what everybody used to read, you're not going to see the ostium. So that's why this diagnosis was a little bit of a mystery for a while. Here's an example of a branch artery pseudoaneurysm in a patient with an IMH. And here's an example in follow-up. So in follow-up, the rest of the IMH can completely resolve, but this little button actually will stay there because it's pressurized. And the ones that we have, they stay there for years and years and they don't go away. But the rest of the hemorrhage can go away. And we have seen cases where it said follow-up IMH, and you look at the study and it looks completely normal. You can't tell the patient had an IMH. Let's talk about ulcer-like projections. So what is an ulcer-like projection? Well, this is an ulcer-like projection. It's a focal divot in the setting of an IMH. So typically you would expect the surface of the intima to be completely smooth, as this is a process of the media. So that will separate the layers so the intima will remain the way it was before the IMH should have been smooth. So here, when we have this focal divot in the setting of an IMH, people believe that this is actually a focal dissection as a consequence of the IMH. That can convert into a full-on dissection or a saccular aneurysm. So we don't use this term ulcer-like projection out, so the patient has to have an IMH in order for me to say that word. So you won't find a report with those words in it unless the patient has an IMH. Here's an example of one of these that converts into a full-on saccular aneurysm. So here we see that this has turned into this. And here's another one actually. So this is all we're talking about, just that little ulcer-like projection there. Notice there's no intimal breach here. And this turned into that. Okay? So be aware of these things. And this isn't going to change the follow-up schedule. So after acute imaging, after acute aortic syndromes, we're going to image them before they leave the hospital. Then we're going to image them at 3 months, 6 months, yearly, biannually if they're stable. Here's an example of an interpretation error. This is an outside study. What do you guys think? IMH? Type A or type B? That's the question here. Is the ascending aorta involved?
Yes.
Yes. Does anybody say no? So that was the read from the radiologist at Cape Cod when this patient came in. Patient came to the Brigham. Repeat study. This is the repeat study. So here's your I minus. What do you think? Where's the IMH?
How long after
4 hours.
Hiding.
Why is it hiding?
Contrast is still in the system.
That's right. So patients, we measured the Hounsfield units. It took us a year to figure this out. Actually, more than a year for me and Aaron honestly to figure out why this patient's IMH went away. So you're a smart dude. Well, we measured the Hounsfield units in the blood pool, and it's 70 Hounsfield units in the blood pool. But you would think intuitively, patient's renal function is completely normal. Completely normal. 4 hours later, their Hounsfield units are 20 Hounsfield units higher than they should be. So be aware that it takes more time than a couple hours to excrete the contrast. We did have the contrast study, and this was an interpretation error. It's going a little bit slow here, but I'll show you. Does everybody, so do you guys think that's IMH? Huh? It looks just like the initial study, doesn't it? But the I minus, that had changed the person's brain that was reading it, and they couldn't figure it out. So what they did was they said that, and this is the cardiovascular attending at the time, said that this is probably atheroma. Well, it's perfectly smooth. There's no calcium. It can't be atheroma. It's connected to the IMH that we know that they have distally. So that was a failure. That person no longer works here. Okay, so we repeated the I minus. Well, I just didn't want y'all to think it was either me or Ayaz, because it's not. So we repeated it the next day. So now it's been 24 hours, and look, you can see the crescentic rim of hyperdensity that goes into the ascending aorta. And here's the metrics where we actually measured the numbers. There you go. Relative versus absolute attenuation. So look for that pattern, the crescentic rim pattern, okay? Penetrating ulcer, penetrating atherosclerotic ulcer. So don't forget that. People like to forget that word. You can't have a penetrating atherosclerotic ulcer if you don't have atherosclerosis, right? This is what it looks like. So we have an intimal breach, usually from a plaque disruption. So that atherosclerotic plaque has eroded through the walls of the aorta. It's become weak, and it's starting to expand. So the ulcerations have violated the intima. Now you can erode into the vasa vasorum and then bleed locally, right? So that's why we see an association with localized IMH in these cases. The very important distinction here is to not call an ulcerative plaque a penetrating ulcer. And the reason is that penetrating ulcer can be an acute aortic syndrome, right? This can be a ruptured phenomenon. But if the patient will present with pain, if the patient has no pain and this is seen incidentally, and you call this a penetrating ulcer, well, that's a problem. So what we want to do is we want to correctly diagnose the situation. So draw an imaginary line around what you think the adventitiate is. Does the outpouching extend beyond that line? If it does, then it's a penetrating ulcer. If it doesn't, it's just an atherosclerotic. It's an ulcerative plaque. Okay, so this is an ulcerative plaque, and this is a penetrating ulcer. Clinically indistinguishable of how they're going to present. Same patient population. These can heal without rupture, but they can rupture. They can be complicated by aneurysms. You can have any other aortic syndrome associated with them at the same time. We talked about the overlap with IMH and dissection. Basically, whenever you erode through the wall, it's fair game. You can turn into an aneurysm, a dissection, an IMH. We talked about the presence of having atherosclerotic disease at the time. It's important to look at these in true short axis. You can be fooled and think something is a dissection just by looking at it in the wrong plane. So if you reformat that in the short axis, you can turn a dissection sometimes into just an ulcerative plaque, actually. So be aware of that. Majority of these occur into the mid and distal descending aorta. So we don't have penetrating atherosclerotic ulcers in the ascending aorta typically. Here's an example of ulcers in the aortic arch. So we see multiples here with the surrounding mediastinal hematoma. So that was ruptured. Here's an example of an interpretation error. So we have the I minus on top, I plus on the bottom. Anybody want to scream out a diagnosis? going too fast, I think. Slow it down. How about this guy right here? Yeah. This is a ruptured PAU. Yep, associated IMH. What about the fluid in the chest? Well, let's take a look. That's where they measured. They didn't measure there. So they missed the hemothorax. I'm serious. This is a live case. This really happened. Because they measured in the wrong spot. So be aware, blood, particularly because it clots, can get hung up in different parts of the chest wall, right? It's not going to flow all the way down and layer perfectly smooth. It can clot up at the top of the lung, and that's the apical cap that we can see. This is just a massive version of the apical cap, where most of the blood is at the top and it hasn't clotted at the bottom. Here's another example. So this is a patient that, this is actually the patient that I showed with the SMA thrombosis. This is the same patient. He had his repair done here. He left to go back to California to get his imaging done. These are the images that were done in California. The report comes back to Mark Bonacca, who's the vascular medicine cardiologist here. He says that report comes back with a penetrating ulcer in his ascending aorta. Now this guy doesn't have any ascending aorta left. It's all been replaced. So the people there weren't aware of his repair and his condition. They said this is probably a PAU. Well, this is a pseudoaneurysm, so his sutures had come apart. This is a missed pseudoaneurysm. So fortunately, Mark had me look at the report. I said, we'll send the images. He sent the images over, and we were able to get him back and fix it. Okay.
Question about that.
Yeah.
Just, I think logistically, or I'm having a hard time differentiating ulcer-like projection from penetrating ulcers. I feel like if you have an IMH,
So don't even think about ulcer-like projection unless you have an IMH,
yeah.
and it's on the surface of the IMH, and it's the secondary process.
Okay.
PAU in association of the IMH is the primary process. So the epicenter of the IMH should be closest to where that ulcer is, expanding out from that point. Does that make sense?
Yeah, but if
So the
IMH
I,
is
so the,
big,
huh?
if the IMH is, so you shouldn't see a large IMH in association with
Right.
penetrating ulcer.
The long IMHs you see, those aren't ones with penetrating ulcers typically. Typically.
There is like an overlap.
Yes. Yep. Yep. But there's those two patterns. The PAU pattern and then the IMH pattern, which just looks like a dissection. Or thrombose dissection, I suppose. Okay. Rupture. So all three layers have been breached. Blood leaks into the adjacent tissues. Without trauma, this does not occur by itself. So we have to have some reason. So here's a 25-year-old kid, motor vehicle accident with chest pain. So here we see a large pseudoaneurysm. We see mediastinal hematoma. And we see compression of the main pulmonary artery. So this was traumatic aortic injury at the level of the isthmus. Here's a 23-year-old pregnant female, 38 weeks with back pain and pelvic pain. This is an unfortunate case. Here we see, which looks like is either an IMH or a dissection that's thrombosed, or we're too early, but we see the dissection flap here. Right? So here's the true lumen, false lumen, both filling with contrast. Here we see the kidneys don't look too great. We see it looks like maybe there's a flap going into the SMA there. Some renal infarcts. Oh, we have a fetus. And we see there's no contrast here in the abdominal aorta. They were able to save the baby, but the mom didn't make it, unfortunately. So you have to think about third trimester for dissection and rupture, okay? Here's a patient. We have another complicated aortic aneurysm here. This is the draped aorta sign. Here we see the left kidney, actually. We see some air in it. So this was a ruptured AAA. Patient devascularized the left kidney and ended up with subsequent emphysematous pyelonephritis. Here's an interpretation error. So the error wasn't made on this particular image. But this is one of the only cases that I have of active extravasation of contrast out of the aorta with the patient on the CT scanner. So here we see contrast just pouring out into the retroperitoneal space. The patient died 30 minutes after this. Okay, so let's see where the error actually occurred in this patient. So 5 days ago, the patient was transferred here. This questionable history of lymphoma. It was a youngish person. Patient had back pain. So they ordered a lumbar spine MRI. And this patient's young, 30s, I think. Lumbar spine MRI. Does anybody see anything? This is the localizers from the lumbar spine MR. Huh? See it? Missed ruptured aorta on the spine MR. This was the images from the spine MR. So notice the saturation band. So they put a saturation band there not to not see the aorta, but to not have the pulsation from the aorta go into the spinal canal, which can cause artifacts. But you see it clearly here, right? Same thing on the axial. You know, this is just the tip of the iceberg. So make sure you look for the aorta on lumbar spine MRs. Now the guy also had a PET, and this is what it showed on the PET. I think he probably had primary aortic lymphoma, because this is what the PET looked like. But he died, and we didn't get autopsy, so we don't really know. Okay, so we reviewed the anatomy and the findings, classification and complications, and some pearls and pitfalls of image interpretation. Thanks for your attention.